We are live.
Good evening, everyone. Welcome to iFocus Online Lecture 214 and the first episode of Squint and Pediatric Ophthalmology. At this point, I must say that we must thank Dr. Mahipal Sachdev sir, Dr. Santosh Navis sir, Dr. Rashmin Gandhi sir, and Dr. Rebika Sachdev ma'am for creating this online platform for everyone's convenience. The postgraduates have been able to gain a lot out of it. I wish during my post-graduation we had such a platform with all the modules ready online for us to see at any point of time, especially for a topic like squint and pediatric ophthalmology, which happens to be quite a tough one. And Dr. Santosh has crafted a very neat sequence of topics that will be taken up. And our chairperson is going to be Dr. Pradeep Sharma, sir. And I'm very happy to have you here, sir. And this will be a 360-degree overall review of strabismus in general, which has never been done before. I request our moderator, Dr. Asha Sandani, sir, Asha Sandani, ma'am, to please introduce Dr. Pradeep Sharma, sir.
Yeah, hello everyone. Welcome to iFocus Strabismus session. This is my great pleasure to invite Dr. Pradeep Sharma, who has been my teacher, and literally he is the reason for what I am today in Squint, literally. Just share.
You want to share your screen now?
Yeah. Is it visible?
Yeah.
Yeah. So Dr. Pradeep Sharma sir has headed the Department of Squint and Neuro-Ophthalmology at Dr. RP Center, and he has trained so many students like me who have been doing like existing in strabismus today, and we have all been reading his book of author of Strabismus Simplified, Essentials and Essentials of Ophthalmology. So Strabismus Simplified is the handbook of Squint. Almost everyone who has been in ophthalm might have read it. And I take very much the pleasure to introduce him. And the good news is he will be chairing our sessions of this Squint. And also I take the pleasure in introducing our co-chairs, Dr. Amitava, and also Sir is currently heading the department in Aligarh Muslim University, and also Dr. Jaspreet. Sir is a professor of strabismus and pediatric ophthalmology in PGI. So now we are going ahead to, sir, I will hand this over to Dr. Pradeep Sharma, who will be introducing Dr. Rebika Dhiman, who is our speaker today currently.
Thank you, Asha, for that grand introduction for this session to begin with. And the rolling in was done by Rolika and Santosh, which was really good. So we are on to a new module, and that's on strabismus. And that will be something which will be really loved by all the people who are going to listen, because we have wonderful speakers. And the first one is Dr. Rebika Dhiman, who was a resident with us, and now she is an assistant professor at RP Center. She is a wonderful teacher, wonderful speaker, and her slides and all are really something that I always used to love and covet. So she is going to introduce the topic of strabismus, starting with anatomy of the extraocular muscles. So over to you, Rebika.
Thank you so much, sir, for such a humble introduction. And I think it means a lot, especially coming from you. And I would also like to thank all the co-chairs, and also Dr. Santosh, who has given me this opportunity. So this is the first talk of the session, the strabismus module, and I'm really privileged to be a part of this iFocus teaching module. So I guess this anatomy of extraocular muscles, it's the basics, because once you understand the anatomy, then only you can understand its functioning, and related to it, you can understand the various pathologies in strabismus and the management of the same. So here I would just like to, before I start with the session, I would just like to clarify that today we'll not be discussing the physiology part, because the physiology would be covered separately. So our discussion would be limited to the anatomy of the muscles, the origin, course, insertion, blood supply, and their actions. So starting with this, while ocular muscles, it has been divided into intraocular muscles, which include your ciliary muscles, the sphincter, and the dilator pupillae. The extraocular muscles includes the involuntary muscle, that includes your tarsal muscles, superior and inferior tarsal muscles. The voluntary extraocular muscle is something that we will be discussing today. So voluntary extraocular muscles, they are 7 in number. First is your levator palpebrae superioris, which is responsible for the movement of the upper lid. Then you have the recti, the 4 recti, depending upon the location. It could be superior, inferior, medial, and lateral rectus. You have the 2 obliques, the superior and inferior oblique. Now, these 4 recti and the 2 obliques, they are responsible for the movement of the eyeball. Now, before we go into the anatomy, just in brief about the embryology. Well, the embryology, just remember that these muscles are developing from the mesodermal part, that is the precaudal mesenchyme and the neural crest cells. So as your eyeball is developing from the optic groove and the optic vesicle, you have a lot of mesodermal structures developing around it. And one of them is the extraocular muscles and its connective tissue sheath. Now, this is a beautiful diagram. You can see the lateral view of the eye and the anterior view of the eye. And it gives you a very clear picture of how the muscles are originating, how they are coursing along the orbit, and how are they inserting onto the globe. So just concentrate on this lateral view, especially at the orbital apex. So what you see over here is the common tendinous ring. So that's the annulus of Zinn. And from this, all the recti, they originate. So then the recti, they kind of form a muscle cone and they take a slightly divergent path. So as they diverge, and after they reach the equator of the globe, they slightly turn inwards. So as you can see, this is the equator, the muscles slightly turn inwards and finally get inserted. The recti, they get inserted anterior to the equator at varying distances from the limbus. Now, recti itself, it's actually a Latin word which means direct. Why do you call it? Because as you can see, it has a direct path from the origin to the point of attachment. Unlike your oblique muscles, which as the name suggests, they are oblique. And why do you call them so? Because they have a much more angular pathway. Starting from the origin to its insertion, it's kind of angled. And you see how different it is from the recti. One is that they do not originate from the annulus of Zinn, which is the common tendinous ring. Then they have an oblique course. And thirdly, they are inserted behind the equator of the globe. So your recti is inserted anterior to the equator and the obliques are inserted behind the equator. Now, this has a clinical relevance, which I'll be discussing later, because this insertion determines the function of these muscles. Now, coming back to the recti, now this is a diagram that shows the annulus of Zinn. So this is a connective tissue ring, slightly oval in shape. What does it encircle around it? So you can see this is the optic foramina. So this is the optic nerve from where the optic nerve passes, and then you have some part of the superior orbital fissure. Then because of this close association with the optic foramen, especially the superior rectus and this medial rectus, they have adhesions to the dural sheath of the optic nerve at its origin here. So this is the reason why, whenever in case of optic neuritis, there is the inflammation of the optic nerve, inflammation of the nerve sheath. So whenever there is extraocular movement, especially upgaze and inward movement, because of this attachment, the patient complains of pain. So pain on eye movements becomes one of the classical features of optic neuritis, and this is the reason why. Now coming on to the course, having taken its origin from the annulus of Zinn, now these recti, they course in a straighter path. As I have told you, they take in a little divergent fashion. Now medial rectus remains kind of almost parallel to the sagittal plane. So this green line, it indicates your sagittal plane, which is the anteroposterior axis. And this is your medial rectus. You see that's almost parallel to your sagittal plane. Now coming to the vertical recti. These vertical recti, they kind of make an angle of 20-25 degrees with your sagittal plane, while the lateral rectus is much more divergent. So it makes an angle of around 40 to 45 degrees. So you see these, the medial rectus runs parallel to your medial orbital wall, and lateral rectus is kind of, running very close to your lateral orbital wall. Now the insertion of recti is also interesting. As I had told you, the insertion of these recti are not equidistant from the limbus. Rather, they are inserted in the form of a spiral. Now, this spiral is because of the varying distances of insertion. So as you can follow this red line, you see that the medial rectus is the closest one, inserted to the limbus at around 5.5 mm. Then comes your inferior rectus around 6.5 mm, the lateral rectus at around 6.9 mm, and lastly you have the superior rectus, which is the furthest, which is around 7.7 mm. So these are all average readings. So there could be variations, individual variations. So this is the average values. So how will you remember this? Well, there's a mnemonic, which is the SLIM rule, with the help of which you can remember, how farther the superior rectus being the furthest and medial rectus being the nearest to the limbus. And that forms your spiral of Tillot's. So why is this information so important? Because when you try to hook the muscles, you must be aware that how further you are expecting the muscle insertion to be, especially in strabismus surgeries, or even in cases of trauma, when you're operating the trauma cases with extensive scleral perf. So where you would like to, hook the muscle, kind of save the muscle by hooking it and repairing the perf underneath it. So this information becomes relevant. Then coming to the levator palpebrae superioris muscle, well, it originates, as you can see, again, somewhere near the orbital apex, but not a part of the annulus of Zinn. So it is originating in the upper parts, slightly superior to your annulus of Zinn from the lesser wing of sphenoid bone. Then it courses anteriorly along the roof of the orbit, and it passes actually superiorly lies your orbital roof and inferiorly lies the superior rectus. So it passes in a very close approximation with the superior rectus, and finally it gets inserted in the form of various lamina. So the lamina insertion is divided into 3 lamina. The upper lamina is responsible for the voluntary eye movements, where it is inserted into the skin of the upper eyelid. The middle lamina and lower lamina are responsible for involuntary eye movements. So middle lamina actually forms your Mueller's muscle, and the lower lamina, which is inserted into the superior conjunctival fornix. So what is the action of LPS? It elevates the superior eyelid. Now, since there is a voluntary and involuntary part, so their nerve supply is also different. Your voluntary part is supplied by the superior branch or superior division of the oculomotor nerve, while the involuntary part, they are supplied by the sympathetic plexus, that is coming from the carotid plexus. The blood supplies from the branches of ophthalmic artery. So what is the clinical relevance? As I told you, that LPS muscle lies in very close approximation with superior rectus. In fact, the muscle sheaths are close together and they form the Whitnall's ligament, as you would say. So LPS aids the superior rectus and elevates the eyelid when the gaze is directed superiorly. So if your LPS is affected, what will happen? You will see the drooping of the lid. Now there's a voluntary part. So as I told you, there's an involuntary part as well. So involuntary part receives the supply from the sympathetic fibers. So in case there's a Horner's syndrome or any other disruption happening to the sympathetic, you see the ptosis, and that is because of the paralysis of the Mueller's muscle. Now coming to the obliques. So first is the superior oblique muscle. Now this is one of the trickiest extraocular muscles that you will have in strabismus. So this is the longest and the thinnest extraocular muscle, which is around 6 centimeters long. And as you can see, this diagram depicts that how this is the annulus of Zinn. The yellow thing is the annulus of Zinn. So your superior oblique is slightly distant from it, and it is originating from the periosteum of the sphenoid bone above and medial to the optic foramen. So your superior oblique actually has an insertion again at the orbital apex. Now, again, coming back to the diagram that we had discussed, in relation to this diagram, this was the diagram of the common tendinous ring. So in relation to this, I would just like to show you, here is your superior oblique muscle insertion, which is separate from the ring and lying slightly superior and medial to it. Then coming to the course of the superior oblique muscle. So this, as you can see, after originating from this orbital apex, it runs parallel to the medial orbital wall, and then comes the trochlea. So from the trochlea, it totally changes the direction of the superior oblique, and it now runs posterolaterally. This makes an angle of around 54 degrees and an angle of around 105 degrees with this vertical recti, the superior rectus muscle. So you see that the trochlea plays a very important role. It actually acts as the functional origin of the superior oblique, and it is acting like a pulley. So a pulley which is changing the direction of the force of the muscle. So because of this functional origin, the superior oblique is directing your pull more anteriorly. And that's the reason why the superior oblique, and it is inserted behind the equator of the globe underneath your superior rectus muscle. Then just in brief about the trochlea, because it's an important structure in the superior oblique anatomy. So what is that trochlea? The trochlea lies at the superomedial angle between the medial and the superior orbital walls. So if you look at the medial part, it is bony, that is made up of some part of the lacrimal bone, and its lateral part is cartilaginous. And in between runs your superior oblique muscle. There's also a bursa, which acts as like a cushion between the two. Now, why this trochlear anatomy is important? Because in case there is any damage, injury to the trochlea, or any inflammation happening in the trochlea, it will affect the free movement of the superior oblique through this trochlea, as a result of which that results in the Brown syndrome or a superior oblique sheath syndrome. All right. Then, as I told you, this is quite a long muscle. So around 6 centimeters long. So 4 centimeters is your straighter part, and your reflected part is around 2 centimeters. The longer the muscle, the longer is the tendon in this case. Okay. So how long is the tendon? Almost 10 mm before the trochlear part and the post-trochlear part entirely is the tendon. Now coming to its insertion. Now insertion also I would like to discuss in detail. So you see, as I told you, the muscle starts running posterolaterally from the trochlea, runs underneath, this is the superior rectus, so it runs underneath the superior rectus and gets inserted behind the equator of the globe. Now this is a fan-shaped insertion, around 10 to 15 millimeters broad. And how further is it from the superior rectus? Well, this anterior end is around 4 mm posterior to the lateral part of the superior rectus insertion, and around 14 mm from the limbus. While your posterior part, it is around 10 to 13 mm from the medial end of superior rectus insertion, and around 20 mm from the limbus. Now, why is it so important? You know, these figures, why are they important? Because hooking the superior oblique muscle is quite tricky. And if you know this anatomy, you know where to, plan your incision. So we commonly plan an incision in the superotemporal aspect. We hook the superior oblique muscle, superior rectus muscle first, and then you try and pull the superior rectus muscle away so that you are able to expose these anterior fibers, which are present laterally. So the hooking becomes slightly easier. All right. So that's about the insertion. Yes. And also there is a difference in function of these anterior and posterior fibers. The posterior fibers of the obliques are responsible for the vertical action. So posterior fibers of superior oblique are responsible for depression, and anterior fibers are responsible for the torsion, which is the intorsion. Now you can question me that why does a superior oblique act as a depressor? Well, again, the answer lies in the anatomy. So if you have heard it properly, I referred that the insertion of the oblique is behind the equator of the globe. So imagine that the globe is a big sphere, and something which is coming from anterior is inserted posteriorly to this globe. So whenever a pull from this muscle comes, it tends to elevate the posterior aspect of the sphere. So as the posterior aspect elevates, the anterior aspect of the globe automatically depresses. So if you understand this, so what we are seeing is the movement anteriorly. So the globe is actually going down, but the posterior aspect is going up. So superior oblique, that's why acts as a depressor, because of its insertion behind the equator. Now here I would like to say that the posterior aspect of these fibers, posterior part of insertion, has close association with the vortex veins. Now these are important structures. So this also acts as an anatomical landmark when you're hooking the superior oblique. And if you see the vortex vein is visible, then probably you can think that you have hooked the entire superior oblique muscle. So this is one of the anatomical landmarks that tell us that we have reached the posterior end of the insertion. And also, you need to be careful while hooking the posterior aspect of the superior oblique to avoid damage to the vortex vein. Now coming to the inferior oblique muscle, well, this is the shortest extraocular muscle, which is around 3.7 centimeters. And this is the only muscle which is originating from the anterior orbit. So superior oblique has a anatomical insertion in the posterior aspect, but has a functional origin at the trochlea. But inferior oblique is actually originating from the anterior orbit. Where? From the orbital surface of the maxilla. So this is in the orbital floor, lateral to the lacrimal groove. Now from here, the muscle is going to pass in a posterolateral direction. And this is your inferior rectus. So the inferior rectus lies beneath it, and it passes as underneath the under the inferior rectus and gets inserted behind the lateral rectus muscle. Again, the insertion that you see is a fan-shaped insertion. It may vary from 5 to 15 millimeters. Now, the anterior end of this insertion, it is around 10 millimeters from the lateral rectus insertion. Again, this is important. Why? Because when you have to hook the inferior oblique muscle, you need to plan your incision accordingly. So we plan for an inferotemporal for initial incision. We first hook the lateral rectus muscle, and then you pull the lateral rectus muscle slightly away so that now you're able to hook the inferior oblique from here. So, and the anterior fibers here again are responsible for your torsional action. So that's your extorsion, and posterior fibers are responsible for the elevation action. And the reason remains the same. It acts as an elevator because it's inserted behind the equator. And here again, you have important structures like the vortex vein around its posterior end of insertion. So be careful when you're hooking this muscle. Also, the posterior end of insertion is actually very close to the point which is corresponding to the fovea. So especially when you have to, passing the sutures and all, you must be careful. Now, since these obliques are inserted behind the equator of the globe and their functional origin is anteriorly in the orbit, so when you disinsert these muscles, they will have a tendency to come anteriorly. That is towards its origin or functional origin. So this is the reason why you can, easily disinsert the muscle even before passing the sutures. So that's what we do. We hook the muscle, we disinsert it, and later on, because the muscle is going to come anteriorly, it will never go back. Unlike the recti, where you hook the muscle, you first pass the sutures, and then you have to disinsert. Because if the recti, they slip, they will immediately retract posteriorly towards the orbital apex, which is their origin. Now, about just a brief word about the muscle fascia and the intermuscular septum. Now, connective tissue which is surrounding these recti and all the muscles is actually the muscle sheath. So whenever we are, dissecting these muscles, you must take care not to damage the muscle sheath, because it, maintains the anatomy of the muscles properly. Then the recti muscles, the muscle sheaths of these recti muscles, they are interconnected. That forms the intermuscular septum. Then also you know that there's a Tenon's capsule which is surrounding the globe all around, which is inserted around 2 mm posterior to limbus. So why is it important? Because when you have to open up the conjunctiva, after that you have to you expose the Tenons, and thereafter you'll have to open up the Tenons and finally expose the sclera. And once the sclera is exposed, it's only then that you could hook the muscle. Now, Whitnall's ligament, I've already discussed. So inferior rectus muscle and inferior oblique muscle, they are also lying very close to each other. So their muscular septa, they are intertwined and they kind of form the Lockwood's ligament. So these are kind of supporting ligaments. And also it's important because these structures, they receive some kind of insertion from the lower lid fibers. So that's the reason why when you're operating on the vertical recti, the superior rectus and the inferior rectus, you must be careful. You must remove these adhesions properly. If not done so, it can affect the lid position. Like too much of a superior rectus recession, it can lead to lid retraction because it's going to pull the lid muscles also. And if you do too much of a superior rectus resection without, cleaning up these attachments, it's going to cause a drooping of the lid. And same thing goes with your inferior rectus muscle. Now, innervation, well, innervation, as you know, it's essentially the 3 nerves which are supplying the 3rd nerve, the 4th nerve, and the 6th nerve. So majority of the supply is from the 3rd nerve. So superior division of the 3rd nerve supplies your LPS and the superior rectus muscle. Then is your inferior division that supplies your inferior rectus, medial rectus, and the inferior oblique muscles. The lateral rectus is supplied by your 6th nerve, and your superior oblique muscle is supplied by the trochlear nerve. So what's the mnemonic to remember it? We all know it. It's LR6, SO4, and rest is 3. Then coming to the blood supply, well, it's supplied by the ophthalmic artery that divides into muscular arteries, and these muscular arteries further branch to form the anterior ciliary arteries. So there are 7 anterior ciliary arteries generally that you will find. So 2 for each of the recti, excepting for the lateral rectus that has a single anterior ciliary vessel. Now, it has clinical relevance. This knowledge is important because as you can see over here in this diagram of the globe, so these muscular arteries form the anterior ciliary arteries, and then they pierce the sclera. and they combine with the long posterior ciliary artery, which is coming along, and they form the major arterial circle, which is present at the root of the iris. And they are also responsible for forming the ebiscleral plexus. So just, in brief, that these anterior ciliary vessels contribute to the supply of the anterior segment of the eye as well. So you should avoid disrupting this supply. So we prefer not to operate more than 2 recti in one eye. Otherwise, it could lead to the risk of anterior segment ischemia, especially in elderly, diabetics, and hypertensive patients. Now, coming to the action of the extraocular muscles. Now, actions, as we know, the horizontal recti. So I have divided this as primary, secondary, and tertiary. So what is primary? When the head is straight and your eyes are looking in the straight ahead gaze. So that's the action in primary position. So medial rectus, lateral rectus, they mostly act in their respective directions only. So they essentially just have primary actions. So medial rectus acts as an adductor, the lateral rectus acts as an abductor. Now things get a little complicated when your cyclovertical muscles come in action. So what are cyclovertical muscles? The vertical recti and the obliques, they have kind of overlapping functions. And that's the reason why they have been given this term cyclovertical muscles. So each of them have a primary, a secondary, and a tertiary role. So in the superior rectus, the primary action is elevation. The secondary action becomes intorsion because it kind of helps in rotating the globe inwards, and your tertiary action is your adduction. Then inferior rectus, the primary action is your depression. Secondary action is your excyclotorsion. That means it rotates the globe outwards. And the tertiary action is your adduction. So you see the recti act as adductors. So both the vertical recti, they act as adductors. And on the contrary, the obliques will act as abductors. Okay. So coming to the obliques, the primary action of oblique is that of a torsion. So always remember, it's mostly a cyclotortor. Now, superiors are intortors. That's the mnemonic. The superiors are intortors. How will you remember? Superiors are intortors and inferiors are extorters. So that's why superior oblique and superior rectus, they act as intorters. So the primary action of superior oblique is intorsion. The secondary action is that of depression, and the tertiary action is abduction. And in inferior oblique, again, it's primary action is extorsion, secondary is your elevation, and tertiary is your abduction. Now, just I would like to, go into detail about these actions. And this was mostly about the primary gaze. Now, what happens when the eye makes a movement towards adduction or towards abduction? So this scenario changes. Now, basically, the muscle action depends upon the visual axis, the angle between the visual axis and the axis of the pull of the muscle. So this is your superior rectus, or the vertical recti essentially have the same axis. So the visual axis and the line of pull of the muscle of the vertical rectus, they make an angle of around 23 degrees. So when the eye is slightly abducted, so the more this visual axis and the axis of the vertical recti coincide, they become more and more of vertical elevators. So SR, when abducted by 23 degrees, it becomes a primary or a pure elevator, and inferior rectus becomes a pure depressor. Okay. Similarly, when you adduct the eye, so the axis, the angle between the visual axis and the axis of the vertical recti, they become more and more at 90 degrees. Okay, so as this angle increases, the recti becomes more and more of cyclotortors. So hypothetically, if you're able to adduct the eye up till 67 degrees, your recti will become the pure cyclotortors. However, that's not possible practically. So just remember that in adduction, the more you adduct the eye, the recti tends to become more of cyclotortors, and the more you abduct the eye, the recti, they tend to become more of vertical movers. So the best position to test the vertical recti is it is in abduction. Why so? Because you are easily able to appreciate the vertical movements. So that's why when you have to check for SR, you ask the patient to look out and up. And for inferior rectus, ask the patient to look out and down. Because what you want to look for is the vertical movement that it is able to bring about. Now, the reverse happens with the obliques. Now, you need to understand what's the axis, the angle between the visual axis and the superior oblique muscle. Well, this angle is around 51 degrees. So now as you adduct the eye more and more, the angle becomes more and more parallel. The visual axis becomes more and more parallel to the line of pull of muscle. So the more it becomes parallel, they tend to become more of a vertical movers. So this is the reason why the obliques become better elevators in adduction, while when they are abducted, they become better cyclotautors, right? So the best position to test the obliques is, how do you test it? We test it in adduction, because you're able to appreciate the vertical movements. The torsional movements are a little difficult to appreciate clinically, but vertical movements you can easily appreciate. So this is basically slide telling about the same thing. In abduction, the recti are the elevators, and in adduction, obliques are the elevators. Now, just revising what we have studied, because it gets a little confusing reading all these muscles at one time and their actions. So your superior rectus originating from the zin, passes parallel to the orbital floor, beneath the LPS muscle, gets inserted anterior to the equator, around 7.7 mm from the limbus, which is the furthest. And this was responsible for elevation, then your intorsion and your adduction. And this is supplied by superior division of oculomotor nerve. Coming to inferior rectus, again, it originates from inferior part of annulus of zin, runs parallel to the floor and gets inserted anterior to equator. It is responsible for depression, the X cyclotorsion and the adduction. This is supplied by inferior division of third nerve. Medial rectus muscle has a very straight course from medial aspect of annulus of zin to the anterior part of the sclera, basically anterior to the equator, and it is inserted closest to your limbus. This is supplied by inferior division of the third nerve, and its action is adduction. In the lateral rectus, it's originating from lateral aspect of annulus of zin, insertion again anterior to the equator, responsible for abduction of the eyeball, supplied by the sixth cranial nerve or the abducent nerve. Superior oblique muscle, it originates at the orbital apex from the body of sphenoid bone, travels anteriorly, takes a turn from the trochlea, which acts as its functional origin, and then inserted, runs posterolaterally, inserted underneath the superior rectus behind the equator. Primary action is intorsion, secondary action is depression, tertiary action is abduction. Innervation, it's supplied by the trochlear nerve. Inferior oblique, it arises from the anterior aspect of the orbital floor, runs posterolaterally, inserted behind the lateral rectus insertion. Primary action is your X cyclotorsion. Secondary action is elevation, and tertiary action is your abduction. This is applied by inferior division of the third nerve. Now, how to test for the intactness of these extraocular muscles? So these are the 6 cardinal positions of gaze that you must know. So medial rectus, you have to test in adduction, lateral rectus in abduction, superior rectus in up and out case, inferior rectus in down and out case, your inferior oblique in and up gaze, and your superior oblique in and down gaze. So you must know about the primary, secondary, and tertiary positions of gaze. This is the primary position with the eyes looking straight ahead. The secondary positions include your elevation, depression, dextroversion, levoversion, and then it's your tertiary position, which is your dextro elevation and depression, levo elevation, and levo depression. So when you are checking for these muscles, remember you are given this 9-gaze photograph, or if the patient, you're looking at a patient, always start from the primary position. You must assess for any limitation, any tropias or any based on the Hirschberg's reflex, or first in the primary position. Then you go on to the secondary position, that is your dextroversion and levoversion, where you will be able to check for the movement of the horizontal recti. Then you go on to the elevation and depression, where you look for cyclovertical muscles. Then in the tertiary gaze, you can break down the for the cyclovertical muscles. So like up and out, your superior rectus, in and up is your inferior oblique, down and out is inferior rectus, and your in and out is your superior oblique. So this is all in brief about the anatomy of the extraocular muscles. And also do test for ductions, which is your uniocular eye movements, as well as versions, which is the binocular eye movements. So this is your primary, secondary, and tertiary gazes. So thank you. I guess I've tried to cover everything possible, related to the anatomy in the slide, along with the clinical importance of the anatomy of the extraocular muscles. So,
Thank you, Rebika ma'am. Yes, sir. Pradeep sir, would you like to say something?
I think that was wonderful, Rebika. You have very nicely covered the applied aspects related to the anatomy, and which we should be taking care of. Like in surgery, you said when you are operating in the vertical recti muscles, you should be careful about the dissection. Otherwise, you may have a drooping of the lid or lid retraction. The same is also true for horizontal recti, in the sense that when you operate a single muscle, it will cause a proptosis because of a recession causing a relaxation of the sorry. Yeah. So there was so if you are operating on a single muscle, and a single large recession would cause a proptosis. And that is why when we are operating on two muscles and sharing the forces between the two, we are rotating the globe and not causing a retraction or a propulsion. So if there is a single large plication or resection, it may cause a retraction of the globe. The second thing which I would like to add is about the vascularity. You nicely talked about the vascularity, that we have to be careful in our surgery. The anterior ciliary circulation actually supplies about 70%. The LPCA is supplying about 30%, less than 30%. But the LPCA, the long posterior ciliary arteries, are only available in the horizontal direction. And that is the reason when we are operating on the lateral and medial recti, we are not so much troubled by the surgeries in affecting the circulation. But there are no vertical LPCAs. So whenever you operate even a single vertical rectus, it may affect the blood circulation, especially in the elderly and people who have a problem with the blood circulation. The other thing which we have to be remembering is there is no recanalization occurring. So there is nothing like after waiting for 3 months, it would recanalize. But what happens is a collateralization. There is a compromise by the other side circulation, which is taken care of. And so we may defer the surgery for the third recti muscle, which you nicely talked about that we should not be doing. And if you have to do a surgery in such a situation, you may use iris angiography to know the baseline status of the blood circulation. So that is something which we should be taking care of. Another point which I think now becomes more relevant in the anatomy is the extraocular muscle pulleys apart from the trochlea. Now, with the work of, you all know, Joe Dhiman, that also should probably, maybe we should be remembering or reading about. The extraocular muscle pulley is relevant to each and every rectus muscle, and of course the oblique muscles. So those are the other things which we should be now reading about, and the imaging that may be relevant. And for that, I will, ask the PGs to be aware of terms like sagittalization and desagittalization of the oblique muscles compared to one another. When we are having both the superior and the inferior obliques, they are balancing the forces. And so if they are in the same meridian, probably it's fine. But if one is getting a little more sagittalized or desagittalized, it would create problems with the motility. So those are the other things which I would like to just add. I would request Dr. Amitava or Jaspreet if they would like to add something.
I think Dr. Rebika did a wonderful job. And as always, Professor Pradeep Sharma plugged a few gaps in all that. But I do want to say that there is now recent evidence by Wright that it is not purely a pulley mechanism. There is an argument that there are some fibers which are telescopic in nature of the superior oblique tendon. Right. So, from a residential point of view, if you want to know the higher levels of knowledge, perhaps that can be added. Demus pulleys, Professor Pradeep Sharma pointed out, and the fact that all these recti muscles, the nerves, they enter from the inner aspect, from the cone. But the superior oblique has the only muscle which has the nerve supply from the outside. And that is why it often gets missed out in a single, block peribulb in the inferior-temporal region. We often have some movement or the other. So that's why where people, in my time, when we used to give retrobulbar, we were invariably, that was in the cone. And we had to give another shot, for the superior oblique. Also, the blood supply and the nerve supply to the inferior oblique comes and attaches to the posterior aspect. So, and in these surgeries nowadays with anterioritization, it can cause what is now being referred to as the anti-elevation syndrome, because it becomes the thought, and perhaps that can also be brought up in for the residence purpose. Yeah, I think that was what, and the fact that I've read recently that, I also grew up saying that, lateral rectus, L for lateral rectus, L for a lone, vessels on the lateral rectus. But apparently that is no more true. They say that these can vary actually. It's not necessarily that, all the recti have two anterior ciliary vessels, anterior muscular, and only lateral rectus has one. Even that is now questioned. That's all.
Right.
I'd like to add a point, sir, here. I mean, first of all, no doubt, excellent presentation, Rebika. I mean, I've heard your talks earlier also. I mean, very crisp and to the point, and very nice, you can see suggestions and points made by Dr. Pradeep Sharma and Dr. Amitava, sir. For the residents, probably, I think the tendinous part of the muscle is very important if you see the applied anatomy, because those are probably the safe limits of the resection, what you can do. So considering the medial rectus, the lateral rectus are much longer tendon probably. So you could go for a much higher resection. So those parts are very important when you're dealing with the muscles. The other thing is basically what I want to point out is, of course, as said, the ciliary arteries. Now the horizontal recti, sometimes there's a question by the residents that you're doing three muscles, you're doing the recti and you're doing the obliques. So the obliques don't have a ciliary artery. So you could do those three muscles, but don't touch the recti if you want to do three muscles. So those are just my 2 points for the residents.
Right, sir, true. Yeah, and the tendon point is really important, as you pointed out, that how long is the muscle per se and how long is the tendon, because it does limit our surgeries, right?
Yeah, because inferior oblique, you see, has hardly a millimeter of a tendon. So you can't be strengthening that muscle, okay? It's weakening what you do. Whereas others, you do strengthening also. So those are some of the little things which probably they should know about.
Yeah, and also there's a point related to the arc of contact, which I thought probably would be discussed in the physiology part. So I didn't go into the detail. So.
No, a wonderful job, Rebika. I think it's really very good.
Thank you, sir.
Thank you, ma'am. Thank you, Dr. Rebika. It has always been an excellent presentation, like always. You are always useful and crisp to the point. And thank you, Dr. Pradeep Sharma. You have chaired very. So we have a few questions from the residents. Sir, in marginal myotomy, do we do that in tendon or the muscle? Do we do that in the tendon or the muscle?
Voice is not clear.
Asha, your voice is echoing.
Okay, so I'll help you with it, sir. Could you explain the relation of inferior oblique insertion to the macula?
Right. So there's this diagram. So it's not related to the macula per se, but basically the point, scleral point corresponding to the fovea. Okay. So as you can see, this posterior aspect, these obliques are inserted quite posteriorly behind the equator of the globe. So if you look at this insertion, the posterior end of the insertion is going way back. And so you see the posterior end is corresponding, around 1 or 2 mm, very close to the scleral point, which is corresponding to the fovea. So you must just be careful, probably if you have to pass a suture, although we rarely need to pass a suture that posteriorly, but you just have to be careful when you're hooking the muscle and not to be very aggressive. And that's the relation.
Right, ma'am.
Ma'am, there is one question. In marginal myotomy, do you do the cuts, the peripheral cuts in the tendon or the muscle? And if so, what is the distance?
I think Dr. Pradeep would answer that better than me.
Yeah. So for marginal myotomy is when we are doing, it has to be 2/3 of width. Then only it will have an effect. So that is one. And single marginal myotomy, usually we may be doing more, two balancing one so that there is an equal positioning of that. So it is not necessary that you do it only on the tendon. You would be doing the anterior, the more proximal one on the tendon and the more distal one or further away in the muscle itself. So there is a possibility of little bleeding also when you do marginal myotomies. But important to take care that whenever we are doing, it should be 2/3 of the width of the muscle at that level. Otherwise, it may not be as effective. Small mini tinectomies also have been described. So those are also there, which may be doing like mini tinectomies to relieve a little bit of tightness of the muscle. That may be done, which may be done either on one side or both sides to give that effect.
Okay. Thank you, sir. Dr. Jaspreet, would you like to add anything on marginal myotomy?
Yeah, I mean, I was just going to say I agree with sir. 70 to 80% of the muscle width has to be there for a good effect. And it's always sometimes it's the opposite sides that sir was saying. Obviously, you go 70 to 80% one side, and then a further distance away, you would do 70 to 80% of the other side. So it's for the small deviation, probably it does work well. And the tenotomy was, as sir was mentioning, probably yes, 6 to 8 prism diopters, probably I think for the horizontal recti with one muscle, you can correct some amount of it. But yes, the incidence of bleeding is there, and one has to be careful about these things.
Thank you, sir. So there is one more question, like how do you, taking the blood supply in consideration, how do you combine superior and horizontal surgery, horizontal recti surgery?
If I can answer that, I mean, horizontal and superior rectus, as I said, probably you should avoid doing the 3 muscle surgery, whatever the horizontal or the vertical recti is. If you want to do, you can say a recession of the medial rectus and some amount of transposition of the superior rectus, probably yes, you could do a half-fit transposition. So those are something which you can combine. But if you think of doing a 3 muscle surgery, probably, or a transposition, a full muscle transposition with a recession of one muscle, probably it's best to avoid them, and more so in the, you can say, in the older age group. I have done in younger age groups. I mean, I did not have any problems, but yes, if possible, one should avoid these things.
And maybe
I can add.
Oh, sorry, sir. Yes, please.
No. If see, one option is to do plicate instead of doing resections, and you know, Professor Sharma has of course taken the matter forward, but we actually randomized and saw that the effect is quite the same as a resection when you save the blood vessel. So that can give you the option for a third muscle that with a little more safety margin perhaps.
And if you have to do a recession, you may do a vessel sparing recession. For the third muscle, if you're doing, then you can do a vessel sparing recession if you have to do the third muscle. But as Amitava has said, for resection, we usually avoid a resection and would do a plication in order to do that. And then another point which is there, that if you have to do, like we have now the options of doing the vertical rectus transposition effect by doing a belly transfer or the Nishida's procedure, in which we are not disinserting the vertical recti. We are just transferring the force by passing the suture in the belly, a non-absorbable suture, and then shifting the vertical rectus force without actually disinserting the 2 vertical recti. So in that case, you may do a Nishida's procedure and the horizontal rectus recession. So there may be 3 muscles tackled, but without disturbing the blood supply. But mind you, sometimes even the Nishida's procedure can cause a disturbance of the blood supply. So whenever you do that, look on the next day post-op for any changes, early changes of anti-segment ischemia. And if there is, then you have to treat that, maybe using cycloplegics and steroids, which may be there in the initial phase.
In fact, sir, after your study on plication, we have actually shifted to plication, and rarely we are doing resections these days.
Yeah,
So it's
For the
equally
medial rectus particularly, yeah, I would.
Yeah.
But lateral rectus, we are still, I think, sometimes doing a resection because of the little more lump which is there. And it is usually a more amount of lateral rectus that we have to do. But yes, that's true that medial rectus, we have almost 99% shifted to plications.
Recently, probably, yes, I agree with you, sir. Recently, probably, I did 2 cases where I did all the 4 recti. So it was a medial rectus recession, Nishida on the superior inferior rectus, and application on the lateral rectus.
Wonderful.
So it did all the 4 muscles, avoiding the ciliary vessels.
Exactly.
interesting, sir. Very nice.
So there is next question. Can the plication be also vessel sparing? Like you have just mentioned, the recession can be vessel sparing. And if yes, then is there any specific method where you can see that the vessel hand can avoid it?
So that's what I think was talked about, that plication is relatively vessel sparing, we may say. Sometimes, yes, it is true for inferior rectus plication. There are studies which have shown that there is a disturbance of the inferior rectus vascular supply. So on the iris angiography, I think Rosenbaum's group from UCLA has shown that there can be a disturbance of the blood supply even with the IR plication in an odd case. But generally, the plications are vessel sparing. So the way you take the bites in the muscle, it should be such that you are avoiding the imbrication of the vessels as far as possible.
Okay, thank you, sir. Would anyone else want to add something on this topic? Dr. Rebika, I think you might have done many vessel sparing plications. I have seen you doing vessel sparing plications. So you want to talk something about it?
I think all thanks to sir, because we have, now totally shifted to plications, and now when we have to do resections, we feel how tedious it was. So, and it's such a bloodless thing, and you can rapidly do it. So as sir told, the only point here is that you have to avoid the vessel. But however, when you tightly, sometimes, you have to tighten it. So sometimes even that suffocates the vessel. However, it is definitely more vessel sparing and as compared to a resection. So I feel once you have a slight learning curve, not much of it, but once you get the hang of doing a plication, you would not want to do a resections.
Yeah, thank you. The next question is, can you please explain the concept of FDT in relation to recti and oblique?
Right. So in case of a forced action test, basically, as you know that whichever muscle you are testing, so FDT is, the purpose of FDT is to check for the restriction, right? So whether there is a restriction or not. So how do you do it? You have to relax the muscle that you are testing. So in order to do that, like if you have to check for the lateral rectus muscle, you use a fixation forceps and you ask the patient. So basically you have to kind of move it in the direction opposite to the lateral rectus muscle. So yeah, normally if the muscle is absolutely fine, the muscle will relax and it will allow the movement of the eye in opposite direction. If there is some restriction, like related to a fibrosis or anything, this relaxation will not happen. So what you will feel in the movement in the opposite direction will be a limitation or a restriction that you can feel. So that means the FDT is positive, okay? Now in case of oblique muscles, now in the recti, you're not supposed to push it in because you have to keep the muscles taut. The more you push it, the more you make the muscles laxed. Now in case of oblique, since the functional origin and the origin is anteriorly, the opposite happens. You have to make it taut. That's why you're supposed to push it down. And then you're supposed to perform the FDT depending on what you're testing. Like in superior oblique, you push it down, out, and from abduction to adduction, you kind of bring it like this. So you have to push it down. So that's why it's called an exaggerated FDT. So that's the difference. So basically it's the muscle that you have to make taut and then you have to check for that relaxation. I think sir would like to add, Dr. Pradeep and Dr.
I do want to say that it's very important, I mean, from the resident's perspective, that the patient should be asked to look in the direction that you want to actually pull the muscle. Because sometimes if they don't, and you're getting a forceps there, and if you haven't been able to explain well, especially when the residents start doing it, the patient is worried when he sees the forceps coming, and he may actually try to look away, and you may get a false feeling that there is some restriction. So it's very important to ensure that he's looking in the direction of interest wherever you want to move the eyes, particularly in the rectus situation.
Thank you, sir. Sir, we don't have much time left, so I have two more questions to ask. What is the importance of ductions and versions and vergences, especially in the examination of children?
Sir, I think if you would like to answer.
Okay. So ductions are basically when you're looking for unilateral eye movements, and versions are when we are looking for binocular eye movements. Now, ductions, when we are looking for, then we are seeing the range of the full movement which is there, like abduction, adduction, elevation, and depression. In binocular version, we are also comparing the movements of the two eyes. So whenever there is, let's say, a paresis, a mild weakness of paralytic muscle, so on duction, it may cover up. So you won't know because the other muscle, the yolk muscle would have got extra innervation, and that would compensate for the lack of adduction or abduction which is there. But this will be seen on a comparative binocular version when we are testing. So versions are comparing the yolk muscle in the direction horizontal or vertical. So these are the dextro version or levo version, and adduction and abduction are unilateral eye movements. The vergences are the movements in the opposite directions, like convergence when both the eyes are working in the inward direction, or divergence when both the eyes are moving in the outward direction. So these are vergences, which is usually looked for in case of fusion or active in convergence or divergence which is happening.
Yeah, thank you, sir. So there is one question from our hot seater, Sonita. Please explain yolk muscles.
Please
explain yolk muscles. Explain yolk muscles.
So the yolk muscles are the two pairing muscles which are doing the same synergistic action. One of the things which I would like to generally say is that when you are spelling yolk, it is Y-O-K-E and not the egg yolk. Many a times I see that Y-O-L-K spelled. So be careful. We are not talking of eggs here, and it is Y-O-K-E, yoking of, like the bullock cart, you have the yoking of the two bulls. So here we are talking of two synergistic muscles. So like lateral rectus and medial rectus is yoking together for a synergistic binocular version movement, maybe a dextro version or a levo version, whereas the two medial recti can be yoking or yolk muscles, synergistic muscles for a convergence action. So the same muscles can be working in different yolk settings or synergistic actions. Antagonist muscles are the opposite action muscles. So, and synergists are working for the same action. So is it clear that yolk muscles are synergistic muscles?
Right.
Also, we can add that the Herring's law kicks in, when we talk about yolk muscles.
Right. Thank you, sir. So there is another question that how often do you do MRI to know the preoperative muscle status and muscle insertion? And what is the role of dynamic MRI in your surgeries?
Okay. So basically for testing for the preoperative assessments, there are various studies done, and I think Dr. Amar Pujari has been working a lot in RP Center on ASOCTs, the anti-segment OCT, which would be preferable because MRI for such a thing may be a little more too much to ask for. But yes, sometimes MRIs can be done in very specific cases when we want to look for a missed muscle. And in those cases you may do, but I think we do not do that often. Dynamic MRIs are a little different. Dynamic MRIs we are doing for innervational squints, like those you have a strabismus fixus problems, convergence, in which there may be a simultaneous abduction. Then you may do a dynamic MRI in different gazes looking for the cross-sectional area of the extraocular muscles. So in different gazes, you are looking for the cross-sectional views of the extraocular muscles and see which one is converging or contracting. So those are in different gazes when we do. MRIs are also done for the purpose of knowing the pre-operative changes, like in Duane's retraction syndrome, there may be absence of a sixth nerve or a hypoplasia of a sixth nerve, or in Mobius syndrome, there may be peribulbar hypoplasia. Again, in CFUM, congenital fibrosis extraocular muscles, you may see a missing third nerve. So there also imaging may be done in specific situations, but these MRIs are to be done with search coils. These are requiring a little more resolution values, so to get to see these nerves.
Right, sir. Yeah. Dr. Amitava, sir, how often do you do the MRIs for the patient, sir?
But a couple of times only, not too often. One reason is that of affordability. I mean, my patients can not afford too much. So unless it's something really bothering me, in which case I might even contribute and money to get it done. It's really, I do it very rarely.
Right,
I think
sir.
sometimes, even CT gives you a good picture of the extraocular muscle anatomy. So we very commonly get a CT done, especially in where we are suspecting fixes, strabismus fixes, or a large angle ESOs with limitation. So we, just because the management becomes totally different if it comes out to be a case of fixes. So that's why even CT, especially if you're looking at the orbital muscle anatomy per se, or if you have to rule out something else like an innervational problem, as I told, MRIs are helpful.
So what Rebika means is CT for myopes. This was fixes convergence in myopes, especially.
Yeah, and even trauma cases, sir. Like if you want to see, look for the, how the muscle anatomy is disturbed and the orbital walls, whether they are affecting the muscles, especially with limitation.
Yeah,
Jaspreet, sir, would you like to say something?
Yeah, just want to add that that's right. I mean, for traumatic cases, no doubt. I mean, CT scan is a really a good investigation. But yes, for others like where sometimes people have done a FES procedure, the ENT procedure, and you have a muscle which is just cut off and gone back. So you probably would prefer an MRI in those cases. But yes, otherwise, basically to know where the muscle position is, if it's after these cases, or to know you can say the thickness of the muscle or the morphology, as in cases of CCDS. No doubt MRI is good, but if you want to know the insertion, yes, as Sir was saying, anterior segment OCT is the best tool to know the insertion of the muscles.
So what's the role of contrast in either CT or MRI? Do you think contrast should be included as a mandatory, or can we skip it if the patient is not well affording?
I don't think so. In most of the cases, probably contrast is not required to know the way the muscle is probably when you're looking for it. I mean, in such cases, which are indicated for the conditions, we refer for MRI.
Thank you.
Right, sir. So there's a question for all of you, and that is the approach of cosmetically hidden phonics-based conjunctival incision for squint surgery anatomically sound, or would it distort the facial attachments?
I've recently started doing phonical surgeries a little late in life. I think I wish I had done it earlier. You see, the evidence of the pudding is in its eating. It works absolutely fine. So I mean, there is no point that it's not anatomically sound. It gives you just the kind of results you're looking for, and it's a remarkably happy patient at the end of the day. The next morning, children are opening their eyes. It wasn't happening when I was doing paralimbal. So I am like really wanting to shift big time to phonical approaches.
Right.
Yeah,
And
but
another thing for phonics incision, which is positive, is that it doesn't affect the blood supply. So in cases of critical blood supply, anti-segment ischemia risk, they suggest that you may choose to do a phonics incision instead of a limbal incision.
Right.
But yeah, limbal incision you would have to do for resurgeries, or when there are a lot of adhesions, when you're not aware what is actually being done, then many a time we shift back to the limbal incisions.
And also, sir, I would prefer that when you have to do large recessions or something, probably I would go in for limbal incision rather than phonics. Probably I feel more comfortable that way.
Okay, so there's a question related to anatomy part, and that is, can the muscle disinsert with the sheath intact?
That's quite possible, because you are disinserting, and along with the muscle, you have dissected it nicely, and it just slips. So with the sheath, along with the sheath, it will. But of course, there will be some attachments to it. So it's not like it's directly going to go back. It will maybe probably hang somewhere in the mid-orbit or somewhere, but it's definitely going to retract, and finding a recti then becomes difficult.
Okay. And what?
Add anything regarding this question, sir?
No, the partial slippages may have the sheath intact still, and some fibers may have slipped. That's another thing which is possible. So yeah, that's right. It can be there. So you may have sometimes only the sheath left and the muscles have disinserted.
So some years ago, when I was using cyanoacrylate glue to stick the muscles, there was this concern. It was raised in, I think somebody wrote a letter to the journal saying that you can stick the sheath back, and what if there's intra-sheath muscle slip? How come it didn't slip? That was the point. Did you put some glue at the cut end, and therefore that also got stuck? Then the sheath and the fibers got stuck. Well, again, I said it worked because all of them were successful. We did a follow-up also, but yeah, there is this concern that intra-sheath slipping of the muscle fibers.
Okay. Another question is that, is there any anatomy-based precaution for passing the sutures through the sclera to avoid perforation?
I think that's a good question, that when we are passing the scleral passages, we have to be careful, especially for resections when the sclera is thin. So here the sclera is thin at the site of the resection. So you should have a stump which is there, 0.5 millimeter stump, so that you are not going to penetrate the sclera deep enough. If it's too shallow a bite, then you may cause a slippage. So you need to have a 0.5 millimeter stump left so that you can pass in cases of the resections, or even in hangback recessions. Again, this is important, that you should have a little bit of stump so that you can pass these sutures without having a perforation. In high myopes, it's a real tricky problems. Whenever we are having very high myopes, even with the most critical care, sometimes we may have the uveal tissue shining. So we may end up having a little bit of penetration, at least if not full perforation.
Right, sir. Is there any logic in measuring the length of extraocular muscles, like because the effective resection is mathematically relative to the length of the muscle?
Not really.
Yeah, I think that's again a very interesting question. Gillies formula, if some of you, the old timers, would remember, W.E. Gillies from Australia had described measuring the axial length. So, and then comparing the recession effect on the basis of the axial length. So, and we know for sure that hypermetropic eyes will yield much more effect compared to the myopic eyes. So the same extraocular muscle which is there for different sized eyeballs will have different effect. So usually the extraocular muscle length doesn't change much, but the eyeball changes, and so it will have an effect on the basis of the axial length measurement. So this is being done by some people.
Like even in pediatric cases, like if you do, yeah. So small resections give you greater.
Yeah, so this is intuitive, you know, that 5 millimeter travel on a small globe is in terms of fraction, is a larger travel than 5 millimeters on a larger globe. So that's true. So at one time, there were people who were, like Sir said, you know, trying to do axial length and finding out regression formulas, trying to build that in, and, you know, like getting something out of it. But I think finally we all end up doing something which works finally in a more simplified manner. So it's not really kicking into and impacting this. It's more of a theoretical concept. That means people are thinking that, you know, will it make a difference?
Right, sir. So just last two more questions, and that is, what is the anatomical basis of lower eyelid retraction with inferior rectus surgery, and how to avoid that?
I think Rebika answered. Yes, you can elaborate once again.
Yeah, so basically, you know, inferior rectus has those attachment with the inferior oblique and also some fibers of the lower lid. So you have that Lockwood's ligament, and, you know, there are some fibers which are inserted. So in case you're doing excessive recession for the inferior rectus and you have not properly removed these attachments, so what's it's going to do? It's also going to pull the inferior rectus, the fibers of the lower lid as well along with it. So what will it cause is a slight lower lid retraction. And if you do excessive resection for inferior rectus without removing these attachments, it will tend to pull the lower lid fibers along with it. So that will cause a narrowing of palpebral aperture. So that's, you know, that's a concept. Even for superior rectus, it works the same.
Right, ma'am. Rebika, ma'am, the last question is back to you as a closing question. What is the embryological basis of congenital aplasia if one of the extraocular muscles?
Well, the congenital basis of all these anomalies, it's very difficult to tell, you know. It's very difficult to say what exactly affects during the development. Anything can happen during the embryological development. So I don't think so there's any specific basis per se for that. Sir, if you'd like to add to this point.
Yeah, I think there are studies which have shown that in the 6 to 8 weeks period, especially if the maternal circulation is having some anomalies, especially related to the blood supply, then it can cause. So malnutrition in a mother in the 6 to 8 week period is known to be causing more of Duane's retraction syndrome. Similarly, usage of the abortion pills, there have been studies have shown that they have caused more of such anomalies because they are affecting the blood supply in the 6 to 8 week period. So this is a critical period in the 6 to 8 week period that the embryological development of the eye muscles is happening, and they can be effective.
Right. So I thank you all for this wonderful beginning of this session. And especially thanks to Dr. Amitava sir, Dr. Jaspreet Sukhija sir, Dr. Pradeep Sharma sir, for taking out your precious time for all of us. And to all the viewers, there are more surprise co-chairs joining next time. So be tuned for that. Would you like to say anything, Pradeep Sharma sir, as we conclude the first episode?
I think I can thank Dr. Rebika, Dr. Amitava, Dr. Jaspreet, and you and Asha, both of you, for moderating so nicely. And I think it's adding to the real charm which is being started by Santosh. So it's wonderful. So thanks for this pleasure.
Thank you, everyone. Our next session is going to be on June 29th. That will be on Physiology of Extraocular Muscles by Dr. Divya Natarajan. So we'll all see you there. Santosh sir, you were saying something, I believe. So your voice is not audible.
Muted.
Sorry.
I think you're muted.
So we couldn't.
I think that's okay. There's some problem with his audio today. Anyways, I'm again thanking all of you for sparing out your time. And to Rebika ma'am, while she's at home, but she was still online for us. Thanks a lot, everyone.
It was my pleasure, and it's always a treat to have such a wonderful discussion with such eminent chairs and co-chairs. And, whenever sir is speaking, I'm also, listening like a student, just like a junior resident. So everything you learn something new. So there's no end to learning, I guess.
Many years ago, I spent a month with Professor Sharma to, hoping something rubs off onto me.
No, true, that's true.
Kind of you. Thank you all. And keep enjoying Strabismus.
Yeah, and sir is there, a great stalwart. I mean, every time it's a pleasure to listen to Dr. Pradeep Sharma, no doubt. I mean, whenever I have all ears to him. Thank you, sir, for being here.
Thank you.
Thank you, sir.
Thank you so much.